my name is Brittany McDowell, and my partner Brian Kowalski and I will be presenting to you all on the topic of muscular dystrophy with a concentration on Duchenne's muscular dystrophy. Our objectives for this presentation are to define muscular dystrophy, recognize the signs and symptoms of muscular dystrophy, explain the pathophysiology of muscular dystrophy, discuss anesthesia considerations for muscular dystrophy cases, and apply our knowledge of muscular dystrophy and its implications to a case study. So what is muscular dystrophy? There are about 9 major groups of muscular dystrophies, each with its own genetic mutations. Duchenne's is the most common, followed by Becker's, which is a much milder form of Duchenne's, and others like facioscapulohumeral and limb-girdle. The term muscular dystrophy umbrellas over all of these conditions and is defined as a group of inherited myopathic disorders involving gene mutations and defects in myocytes. Alterations in the integrity of myocyte cellular membrane due to the variety of mutations, which causes a progressive muscle weakness, is the overarching theme of muscular dystrophy. Since Duchenne's is the most common of the muscular dystrophies, this presentation will mainly focus on Duchenne's. It's one of the X-linked recessive inherited dystrophies, which explains why it's much more common in males. Female carriers, though, can present with muscle weakness without having the full extent of the disease. Duchenne's is usually diagnosed while children are in early childhood from about 2 to 6 years old. Other forms of muscular dystrophy can be diagnosed in adulthood. In a patient without muscular dystrophy, a healthy muscle cell has dystrophin proteins between the sarcolemma and the cell's membrane. The dystrophin acts as a stabilizing agent to strengthen the muscle fibers, protect the cell, and maintain the integrity of the cell membrane. In Duchenne's, mutation occurs in the gene that encodes dystrophin, where either dystrophin is not produced or production is severely decreased. Without dystrophin, the muscle cell's membranes have structural integrity concerns and are at risk for injury. Symptom severity correlates with the amount of dystrophin in the myocytes. In healthy patients, dystrophin can be found within the skeletal and cardiac myocytes, the brain, and the retina. The most obvious symptom of any muscular dystrophy is muscle weakness. In Duchenne's, proximal muscle weakness is noticeable before distal muscle weakness. For example, bicep strength weakens before grip strength. In toddlers, they're often late to learn to walk, have unusual gaits, and are especially clumsy. Duchenne's patients must rely on wheelchairs by the age of 13 usually as the weakness progresses. Pseudohypertrophy can occur where the muscles look large but are inherently very weak due to the fibrosis and scar tissue that's formed over the years of injury to the myocytes. Duchenne's patients can have dilated cardiomyopathy, arrhythmias, especially arrhythmias related to conduction delays, and valvular dysfunction. The most common valvular problems are mitral valve regurg, and that's related to failing papillary muscles. Cardiac symptomology increases as cardiac myocytes weaken and get more fibrotic. By the teenage years, ejection fraction is usually less than 55% and progressively declines as the patients develop biventricular failure. Scoliosis is also usually present in nearly all Duchenne's patients. As it progresses alongside the progressive muscle weakness, it causes a restrictive ventilatory pattern, which leads to decreased vital capacity, decreased baseline oxygenation, and acute respiratory failure. Respiratory complications are often the primary cause of mortality in Duchenne's patients, and cardiac complications are the second most common cause. Life expectancy in Duchenne's patients has increased over the past few decades due to medical advances. However, today the average life expectancy is still only 27 years old. Muscular dystrophy patients need an extensive pre-op eval due to the associated comorbidities. As we discussed, especially as they age into their teenage years, these patients have extensive cardiac and respiratory impairment and are at high risk for anesthetic complications. It's important to know their baseline, which is why PFTs and ABGs are beneficial. They also have a tendency to have a larger than average surgical blood loss, but the exact mechanism for this coagulopathy is unknown and debated in the literature. For these cases, we need the patients to be typed and cross-matched with blood on standby. Cell saver machines are also beneficial to have ready as well for invasive surgeries. Thromboembolic events are also more common, but this is likely due to their decreased level of activity. We want to use minimal pre-op sedation in these patients due to their pre-existing weakness and not wanting to exacerbate any pre-existing restrictive ventilatory patterns.
All right, so intraoperatively and even with induction with these patients, they should never receive succinylcholine. SOX actually has a black box warning for risk of cardiac arrest and sudden death due to hyperkalemia. There's actually a change in the post-junctional receptors due to dystrophin absence, like Brittany has spoken about earlier, which increases the chances of this patient population experiencing elevated potassium levels. These patients have an increased risk and sensitivity to non-depolarizing neuromuscular blockers. Most commonly, we'll see it with rocuronium, and just meaning what we use most often, the recovery time will be prolonged. And we'll actually discuss this in the case study in the next slide, so try and keep this in mind going forward. And while there really isn't an associated risk, an increased risk of developing MH, the symptoms may look like this in a patient during anesthesia. This patient population is sensitive to the myocardial depressant effects of inhalational agents. So in this population, those should be avoided. And the anesthesia recommendation is really to use TIVA, which is total intravenous anesthesia, as a method of keeping this patient population sedated. A few more housekeeping notes is to avoid nitrous oxide due to the increased risk and high incidence of pulmonary hypertension. There is gastric hypomotility in this patient population, so a lot of times we'll use nasogastric tube to decrease aspiration risk because this can decompress the stomach. And if this patient has been on long-term steroid use, consider that you might want to use a stress dose steroid for this patient. All right, so now getting into the case report like we just spoke about, this is about an 11-year-old male who was diagnosed with DMD at 1 year old. The surgery is a percutaneous nephrolithotomy, so a pretty straightforward case. And the preoperative evaluation and assessment found significant findings with the EKG. So there was right ventricular hypertrophy, which we spoke about earlier as an increased risk and something to look out for in this patient population. And there were elevations in the creatinine kinase and liver enzymes with the ASTs and ALTs as well. All right, so for induction medications utilized during this case were pretty standard outside of the use of the non-depolarizing neuromuscular blocker rocuronium at the end. So Versed 5 milligrams is given, and then there was a propofol infusion and a remifentanil infusion started. The propofol infusion was at 250 mics per kg per minute, and the remi was at 0.3 mics per kg per minute. Now the use of rocuronium was at 0.6 milligrams per kilogram, and usually this is not used in the patient population because of the increased sensitivity, which we'll get into in a minute as well. And then at the end of the case was about 90 minutes long. The patient was reversed with sugammadex at 2 milligrams per kilogram, and this was based on the patient's train of 4 and other signs used for that reversal. The patient was extubated 15 minutes after receiving the reversal, and there were no complications with that extubation or in the PACU hours later. All right, so what about the implications for this? What can we expect after using a neuromuscular blocker in this patient? So as we saw in this case, the patient still took a full 15 minutes to have reversal and be extubated. With a normal patient, we would see reversal of rocuronium with sugammadex in probably 5 minutes at most, and usually we would see within 2 to 3 minutes. But as we discussed earlier, the duration of action is prolonged and the effects might last even longer, and you might even see increased risk of recurization with this patient in the PACU hours later because we don't know the effects and how long it's extended with this patient population. So the other question you might ask is, why not use rocuronium for all these patients if we can reverse it successfully, especially with the use of sugammadex? And the big thing here is that sugammadex isn't actually approved by the FDA in the U.S. for pediatric population. Now, this may change in the coming years, and studies in this patient population might become more prevalent, but for now, it remains without recommendation from the FDA, so we still can't use it. All right, and just to kind of summarize what we've talked about throughout this presentation, with the muscular dystrophies, there's issue with the dystrophin protein. This is usually found in early childhood in males. With children, it's usually found between the ages of 2 and 6, so we know how to tailor our anesthetic plan, but it's always something to be aware of. You should never use succinylcholine in this patient population, and you should always try and use TIVA with a total intravenous anesthesia, and avoid the inhalational anesthetics as well because of those myocardial depressant effects that we talked about earlier. There can also be significant involvement in other organ systems, and the big ones being cardiac and respiratory changes, and this can obviously change our anesthetic plan, so it's something that you need to be cognizant of going into the case.
Question number 1, true or false? Duchenne's muscular dystrophy affects distal muscle groups earlier and more severely than proximal muscle groups. This is false. Proximal muscle groups are affected before distal muscle groups. Question number 2. True or false? Succinylcholine is the drug of choice for induction in patients with muscular dystrophy. False. Succinylcholine should be avoided in muscular dystrophy patients due to the risk of rhabdomyolysis. That concludes our presentation. These are the references we used to compile this presentation. Thank you for your time.